Well, welcome everybody to Optometric Education Consultants National Webinar Series, Tuesday night edition. Tonight, we're going to be talking treatment of pain, opioid choices, and issues for the patient and practitioner. And our speaker will be my partner, Dr. Greg Caldwell, who's a graduate of the Pennsylvania College of Optometry, where he also completed a one-year residency in primary care and ocular disease at the Eye Institute in Philadelphia. He is a fellow of the American Academy of Optometry, a diplomate of the American Board of Optometry, a member of the Optometric Glaucoma Society, and a member of the Optometric Wellness and Nutrition Society. He currently works in Duncansville, PA, as an ocular disease consultant. His primary focus is the diagnosis and management of anterior and posterior segment ocular disease, and has been a participant in multiple FDA clinical trials. He has integrated nutrition, prevention, and wellness into his patient care. Thus, he practices integrative optometry. He's a co-founder of Optometric Education Consultants and co-administrator of OCT Connect on Facebook. He has lectured extensively throughout the country and over 13 other countries internationally. In 2010, he served as president of the Pennsylvania Optometric Association and served on the AOA Board of Trustees from 2013 through 2016. And he's president of the Blair Clearfield Association for the Blind. So with that, please give a nice virtual round of applause to our speaker, Dr. Greg Caldwell. Greg, take it away.
Thanks, Joe, and thanks everyone for attending. And this course kind of birthed out of just the requirements from the state associations, people having DEA license. So hopefully this covers your requirement. I'll try and make it as lively as possible, as much as we can with opioid choices. And then, if you don't need it for DEA, then what you can do is use it for pharmacology. So with that being said, here's my list of disclosures. Probably the most important ones on here. The content and activity is independently prepared by me. You can see who I've lectured for in my advisory reports. I don't really put that on there to really impress people. I put that on there as a guy from Duncansville, Pennsylvania, that's going to go out and have the privilege and honor to teach and lecture to colleagues that I need to stay up to date. And we just finished the academy last week, and that's why I'm still in San Diego. And I met with a lot of these companies, and man, am I ready to kind of reload and recharge those slide decks out there and bring the latest and greatest that's out there. With that being said, I'm going to jump down to pretty much, because this is opioids, there's not too much I have to disclose on here. The content and the format of this course was presented without commercial bias and does not claim superiority of any products or services. So if I mention anything, or just because it's my opinion, you guys are docs, you can figure out what you want to do in your practice. And as Joe mentioned, co-owner in Optometric Education Consultants, you can see our 6 meetings that we have. And now 7th, because here we're going to Heidelberg. What is that now? Heidelberg, Germany. It was switched from Strasbourg, France. So, here's really what sums up. I'm a clinician first and then a scientist. I just sat through the OGS while being out here, and tons of science, that's tons of science that comes from that meeting. But, science is great if you can't apply it clinically. So I think that's what Joe and I strive for with Optometric Education Consultants, is to take all this science, all this, if you want to call it evidence-based medicine, or now outcome-based medicine, and try to apply it in our clinics. And Sarah summed it up here as, in a quote that she sent us, it is wonderful to have someone who's juggling so many aspects of optometry science, clinical, teacher, lecture, refreshing. So that's kind of what I try to do here. Here's my practice. I have this building. We have 6 exam lanes. I'm one of you that's out there and just going out and doing it. And I love presenting to our colleagues. This here, I usually don't go over the agenda, but I put the agenda in there just because I know states need it for their DEA. And so I pretty much scoured most of the states out there. And that's why we need to talk about the opioid crisis and talk about the definition of pain, and then opioid adverse drug reactions, intolerance, and true addiction. If there's something in there that I'm missing from your state, just let me know and I'll add it to the agenda and maybe put a slide or 2 in there, because we want to make sure that we have this as comprehensive as possible that's out there. so that it does count for your opioid credits, at least 2 hours. I know Arizona needs 3. So with that being said, Joe, can you just launch that first polling question here? I'm taking this
I
course
shall.
because, yeah, I'm just curious. Are you taking it because you have a DEA license? I have a DEA license and it's required. I know those are kind of close, but I have it set up as I think you can answer, more than one. I need pharmacology credits. I'm interested in the topic, or, you can put your comment in the chat box. New Jersey requires all ODs to have an opioid course. All right. Thanks, Bethany. Heather, you're more than welcome. We enjoy helping you guys out.
Okay, we're doing really well. People are
They're being interactive.
yeah, we're up to 85% participation already. So I'm going to end it and share the results. And it's no real clear leader.
Yeah, a couple 21% with the DEA license, or maybe 50%. That's great. 50%. I'm not sure if people answered twice there. Need some pharmacology credit and interested in the topic. All right. So Joe, I'm actually just going to close this out. So it's off my screen since I'm working from a laptop. I'll let you be in control. So the National Institutes on Drug Abuse in March of 2018, the National Institutes of Health saw that every day more than 115 people in the United States die after overdosing on opioids. Now, I'm not going to read this slide to you. I'm not a big slide reader, but I will show you the words that I highlighted, right? They talked about the misuse, and it's a national crisis. And again, a misuse and the burden, the economic burden at that time, it's probably grown bigger than that. Maybe hopefully these programs have slowed it down, but it was $78.5 billion a year. And you can see here that 21 to 29% of patients prescribed opioids for chronic pain misuse them. That's a pretty big one there. Just kind of remember that, because when we get to acute and chronic, you'll see how, we as optometrists are probably not a big deliverer of this, because again, it was chronic pain. And then develop an opioid use disorder. That was between 8 and 12%. Misuse prescription opioids transition into heroin, right? First misuse opioids. And again, opioid overdose increased 30%. So overdoses, and then opioid overdose in large cities. So those were that's kind of how we got there. I guess I should have made this a polling question, but is this our first opioid crisis in the United States? And the answer is no. This is actually our third opioid crisis. It always seems to be an opioid crisis at the beginning of the century. There was one at the 1900s. There was one in the 1800s in the United States. So this is actually our third opioid crisis that's out there. So in the summer of 2017, the National Institutes of Health met with the pharmaceutical companies, and they were trying to get safe, effective, non-addictive strategies to manage, their chronic pain. See, we have to pay attention to chronic pain, because we as optometrists have to take this course. We're going to be dealing with acute pain. And some of us out there have just limitations, 3 or 4 days. Now, not to say that you can't become addicted just with one use. So I'm not taking that away. But the patients that move from opioids into maybe some issues, or into heroin, as we talked about a little bit earlier, that's more or less the chronic pain that's out there. Now, we'll do a couple of slides here. We'll talk about pain. Pain is useful to our survival. Pain is defined as the perception of harmful stimulus. Pain can also occur in the absence of injury long after it is healed. And, we see that sometimes with post-herpetic neuralgia. That's more of a neuralgic pain. But pain also provides humans with information about tissue stimuli, thus enables us to protect ourselves. Pain is protective in 2 ways. It removes the patient from the stimulus and withdrawal reflex, And pain is associated, cause person to avoid a stimulus previous, that caused pain. Probably the best way to sum that up is, how many times did we to ourselves as a child, don't touch, I was, growing up on the, with my dad using tractors, hey, look at that muffler. Don't touch, dad's not there. One time, touch the muffler after it's been running for an hour, cutting the grass. Ow, I burnt myself. No, I shouldn't have touched that. My dad warned me. Touching the stove. Guess what? I'm not going to touch the stove anymore. I'm not going to touch that muffler anymore. So that helps us. And, we quickly pull our hand away when we touch things like that. So the somatic sensory system, I just wanted to kind of remind everyone, diverse sensory system composed of receptors, processing centers. We talk about touch, temperature, proprioception, our body, close my eyes and I know where my hands are. And here it is, nociception, which is pain. I thought this was kind of cool, the part of the brain here that registers pain. And this was a cute little drawing here showing how much our head and our lips and our hands are involved, and very little to our body is given up in the, if you look through this gyrus part of the brain here, you could see how much is dedicated as pain receptors. And you'll hear this kind of referenced as central acting. That's part of the central acting part of the system. So, and there's different types of receptors out there. Remember, thermoreceptors, and there's pain receptors, mechanoreceptors, and chemoreceptors. Now, pain is unpleasant sensory experience associated with actual or potential damage to the body or a perception of such damage. And it is subjective in experience. Memories of events associated with extreme pain persist for a long time. Mental state is known to have overpowered the influence of pain, right? And we've, football season is here, and we hear of players who get injured and then they play the rest of the game to find out that they have a cracked or broken bone. So their mental state, or we hear the heroic part where a soldier is in battle. He or she himself has been wounded, but he or she drags off two other soldiers to get back to the camp or some heroic event, get them onto the helicopter, get them into the vehicle, or get them protected, to find out that they've been wounded themselves. So pain can be overcome by, the mental state that's out there. So when it comes to pharmacology of pain, we have peripheral acting agents, and then we have central acting. That's kind of the big ones that I'm going to kind of focus on tonight. Peripheral acting, pretty easy. That's your ibuprofens, your NSAIDs. We have central acting, which is what we're going to be talking about tonight. And that's why we're here, these opioids and narcotics. Then people ask, well, where do anesthetics fall in? Well, basically, they just prevent signaling to the cortex. So they're more of a signaling inhibiting agent. And that would be your anesthetics like proparacaine. So we're going to talk peripheral acting, central acting. And it's really the last time you're going to hear us talk about signal inhibiting agents. So I thought this was pretty cool when I was looking at this. This is more kind of, the cartoon's pretty accurate, but what I want to do is talk about, here's this flame and it's burning your hand. But how many times have you've touched something hot, you remove your hand, but then you go, ouch, right? You've already kind of pulled your hand away. And that's just because we're just amazingly wired as humans. You can see that the receptors have already been have the stimulus of pain, and it goes right through the spinal cord, right back out to pull your hand out, activate those muscles before it does go up to that part of the brain that we talked about and says, hey, get your hand out of that fire, and you go, ouch, right? So we're just wired just amazingly. That's why if you touch something, you automatically start to kind of pull off, and then you go, ouch. That's because it doesn't have to go up to the brain. It goes right back out that one of the anterior or dorsal roots of the spinal cord here to get that hand or whatever body part out of the way. Now, so a lot of people thought back in the day that peripheral acting meant just kind of peripherally acting on the hand, and central acting was just working in the brain. And I have a slide coming up here showing like where all these now mu and kappa and delta fibers are all located, and they're located all throughout the body. So a lot of the time we thought that opioids were just kind of plugging into the brain here, and that was the only spot. And the answer to that is no. We have, I lecture, and sometimes I do this lecture with a pharmacist. You guys probably recognize the name, Dr. Tracy Offerdahl. And, she has taught me so much in pharmacology, but she also has taught me pretty much everything's about the receptors, right? How's the affinity with the receptor? How's it interact with the receptor? And really, when we talk about opioids, it's all about the receptor, these mu, delta, and kappa receptors that are out there. So with that being said, Joe, we're going to launch that polling question number 2. And it is, what type of pain does not respond well or at all to opioids? Is it that nociceptive pain, or is it neuropathic pain? There's other types of pain that we're going to talk about, but when it comes to opioids, and this is going to be kind of part of maybe I'll reference it again whenever we get to the part of being, a detective, and when the patients come in trying to be tricky. So this is kind of part of the program here of learning that what type of pain does not respond well at all to opioids.
And Greg, there are no questions for you yet in the chat, just
Great.
comments that we've all kind of addressed, are very good comments about requirements of why they're here.
Great, perfect. Thanks for being my eyes tonight, Joe, and being a great co-host here.
And I'm going to end it now and share the results because I like the way it turned out.
74 and 74. Can't get more split than that, can we?
50-50. Excellent, guys.
Yeah, perfect. All right. So maybe I should have put a follow-up polling question in here afterwards to show the learning experience. All right, so let's jump in there. So there's, 4 major types. I'm sure that you could probably keep doing research, 6 types, 8 types, but nociceptive pain is usually due to body injury, inflammatory pain, an abnormal inflammation caused inappropriate response by maybe the body's immune system. Neuropathic pain caused by nerve irritation. That's kind of our post-herpetic neuralgia. And then there's functional pain, pain without any obvious origin. It's actually the neuropathic pain that does not work well with opioids. And that's important to know because, someone comes in and they say, hey, I had some herpes zoster. Hey, doc, it was around my eye. And man, does it hurt? The only thing that really works on this is Oxycontin, right? Well, you could maybe now use, as Dr. Andy Lee would say, your superpower that's out there and say, you now know that neuropathic pain that was caused from this herpes does not really work on that type of neuropathic pain. So this is not going to be the focus of today's discussion, but it is relevant. You just need to know about it. That's out there. Neuropathic pain does work somewhat well with some of these Neurotins and Lyricas, gabapentin. You'll see sometimes people using it like Ambien that's out there, Valium working with it. You're going to see probably some really cool stuff happening with neuropathic pain now that CBD is legal and everyone's kind of working through high quality CBD. We'll probably have a higher chance of working in that endocannabinoid system. And I do have some slides at the end here to talk about that whenever it comes to finding alternatives. So it's that neuropathic pain that does not work well with NSAIDs or steroids or, your non-steroidals, or that peripheral acting or central acting doesn't really help you out there either. So neuropathic pain could be the trigeminal neuralgia, post-herpetic neuralgia, diabetic neuropathy that's out there, phantom limb, pain from multiple sclerosis. I'm not going to read this list to you. These do not respond well to, say, Tylenol ibuprofen, and any of the narcotics that's out there. So the answer was neuropathic pain to that question. And that's why you see things like anticonvulsants and tricyclic antidepressants being used from time to time for this neuropathic pain. Now, chronic versus acute, right? So we as optometrists, this is where we're going to be most of the time. We might have someone with a testicle eye that doesn't want to have surgery, doesn't want to have it removed, and maybe we're moving into some type of chronic pain. So when I lecture with, Dr. Offerdahl, the pharmacist, she does have her own apothecary that's out there, and she talks and she does manage chronic pain. And, we're going to be talking about ceiling effects and different things here tonight. But those aren't too many things that we have to worry about. Someone, scratches their eye or penetrates their eye or nearly penetrates their eye with an injury. We're going to be using something like Ultram or NSAIDs and ibuprofen and Tylenol to manage their acute pain. They'll probably only need it for 3 or 4 days. So acute pain versus chronic. And the goals are different. They do different, right? So the goal for acute pain is to keep the patient as comfortable as possible while minimizing the adverse drug effects, right? So that's acute pain. Someone scratches their cornea, takes off, 90%. We want to keep that patient as much as quiet as possible while they heal up. The goal for managing chronic pain is a little bit different. It's to keep the patient as comfortable as possible. This does not mean pain-free, and you're integrating the patient back into normal life. So there's people that have like chronic back pain. You might not make them pain-free, but you give them enough coverage in those receptors to allow them to say, hey, I can go to work again, or I can drive that car, or hey, I can, golf again, or I can go to Disney and hang out with my family, for a week. So the difference are there. So you're just trying to get the patient just to that point, again, where they can be integrated back into life. So acute versus chronic, and that's in there because whenever I read the state regulations, we have to cover acute and chronic pain. Pain assessment scales, do I keep this? My dad was recently in the hospital the last, few weeks, and you'd go in and you go to the different hospital rooms and the different places, and you would see up on the walls, the smiley faces, the 0 to 10. Like, we don't need that in optometry offices, but a lot of us have computers in the exam room. So a really nice way to get one would be to just go to Dr. Google, type pain assessment scales, and pull up, one on the computer that's out there. So, pain assessment scale adds objective data to the patient's feeling. It does does the injury or wound or diagnosis fit the patient's presentation that's out there. So with that being said, I do have a polling question here, Joe, to make this live and interactive for our participants out there. Do you use a pain scale when prescribing narcotics? Yes, no, I don't prescribe narcotics. Or if you want, you can place a comment in the chat box if you do something different, or if you want to make a comment to the group. So anytime you guys want to make a comment, that's part of the live and interactive. I have them kind of opened up here in the corner, but I know Joe is policing this well tonight.
And we're getting a pretty rapid response like we have it all night. And I think I'm going to stop it already because we got a great response. It's a pretty straightforward question. So I'm going to share the results.
Okay.
And, Greg, the majority do not prescribe narcotics. Of those that do, some are using a pain scale.
Yeah. So the only thing I'm going to do is just encourage. I see there's 12 out there that thank you for answering that way. We don't know who you are, but thank you for answering that way. I would encourage, at least from putting this course together and working with different pharmacists and the agencies that regulate this, is to, consider, like I mentioned, pulling up on the internet, a pain scale. If you're going to
Greg,
prescribe, go ahead, Joe.
I'm gonna jump in here because a couple people made some comments here, and it was a question posed, I think, to everybody, and people are responding. And I think like to hear what you have to say is, how often do you prescribe narcotics? And the response is so far rarely. What people are saying here.
Yeah, I think there's a handful of times throughout the year. Probably my maximum would be 4 times a year. I'll say once a quarter. It happens. Ultram is my go-to. 50 to 100 milligrams. That's usually, now my practice, I'm the one that typically sees most of the emergencies whenever I'm not traveling. So I get to see some pretty, fun stuff, if you want to say that. In a twisted way. So at the end here, I'll show you some injuries that came in where I've used a narcotic. Here's the key out there, ladies and gentlemen, is that ibuprofen given over time will, it's not if, but will cause some type of bleed or ulcer to the gut. Now we're not talking chronic here, but when it comes down to narcotics, other than addiction, which anyone can take and become addicted, they are super, super safe, right? We're in this era where they're not safe, but if we were doing chronic pain, that would be totally different. So I would kind of lower the threshold. We have all these statistics that are out there, but remember, if I'm working in acute pain, I would consider, lowering that bar. Here's another thing. As long as a patient is not going to go out and operate a vehicle. And this is the other thing that if I hear, man, this eye pain is killing me. If I could just go home and get a good night's sleep, I think I can get over the hump here. And that's the old, hey, do I have a deal for you, right? Because one of the things that, that narcotics, whether it's, the hydrocodone products, or the Ultram, they do create sedation. They do help people sleep. So if I have someone that's not going to operate a vehicle and they want to try and get a good night's sleep, that's whenever I'll reach out. So Joe, probably my highest has probably been 4 to 6. I mean, when I worked in the ODMD practice and we were doing PRKs and PTKs and doing a little bit more, maybe it was monthly, maybe every other week. But, as a person in, private practice, probably once a quarter. What about yourself?
That's very, very rarely. I'm in an ODMD practice, and every quarter we have a week of on-call. And on-call for us is, for 30 different providers, ODs and MDs, people doing surgery over the course of 9 offices in about a 30-mile radius. So, there are some pretty serious things that come in. But you're right, it isn't common even in ophthalmology. In fact, when I was testifying in Maryland for their amplification, Maryland was looking for something very similar to what we have in Florida. 2 controlled substances for a max total of 72 hours. And the opposition ophthalmology, in their testimony got up and said, look, we rarely even use that. Why would optometrists need it? And it's kind of hard to argue because they don't use it very often. Even ophthalmologists don't use it. I mean, if you've got oculoplastic surgery, I can understand they might be using that. Maybe strabismus surgery, I can see where they might be using that in adults. But for the most part, there are a lot of non-opioid pain controlling things, including the good old-fashioned atropine.
Exactly. When we get to some of the alternatives, which these courses have to cover, I'll make sure that we cover some of that.
Great. Something came up in the chat room. I'm not sure if you're going to talk about it in just a little bit. And I was actually looking for a citation here: dual action Advil. What are your thoughts on that?
Actually, I think they finally came out with an Advil that has some acetaminophen in it. And when we get to alternatives, we will certainly cover how that works. And some, basically that's probably where I spend 90% of my time is prescribing 400 milligrams of ibuprofen with Tylenol or 800 milligrams. And I'll go through that kind of little algorithm when we get there. So, yep.
And what is your go-to for post LASIK? Is somebody asked, and as Heather asked in here.
Yeah, I'd probably do Ultram, any of the PTKs, PRKs, and you're going to see as we get there, we have to be careful when we talk about narcotics. There are immediate release and controlled release. Immediate release is where we want to spend the acute. So immediate is acute, and then kind of that sustained release or controlled release or chronic release. That's more for your chronic pain. So when we get to when we talk about Ultram, when we talk about the hydrocodone products, you'll see, I've never really seen Tylenol with codeine work really, really well with ocular or corneal pain. That's why I was bummed whenever we got legislated out of the hydrocodone. But Ultram is probably the easiest and the safest to go to, and it's a category 4 on the scale that's out there.
And when you talk about the PRKs, the Epilasic, the PTKs, the SKs, that bandage contact lens comes off, they get a problem.
Yeah. So, bandage contact lens will be talked about in the alternatives. But those cornea nerves, the cornea, remember, is the most innervated part of the body. So just adjacent is the conjunctiva, which isn't innervated that well. But the cornea, man, as we all know, unless it's a neurotrophic keratitis or a neurotrophic cornea, we know that it's painful if you just get a small little abrasion. Great discussion. When I get to some of those slides, we can just kind of breeze right through them because we kind of chatted about them. I'll hit the highlights. Anything else, Joe? Great conversation. Love it.
Well, somebody just came in. I don't think Heather finished her question, so we'll come back. Come back to that. Oh, yeah. You previously mentioned another lexicon of Tylenol and ibuprofen to achieve good pain management. I think that's what we're talking about, the dual action Advil.
Yeah, well, dual action Advil finally came out where I believe it has. If someone wants to look it up, I believe it finally came out where they put Tylenol in it. That's what they're talking about, dual action. They put Tylenol and the ibuprofen. I believe it's finally now here in America as one. I'm not sure we can look it up, or someone can maybe Google it while we're on here and put it into the chat box. But dual acting, meaning that you got acetaminophen being one action, which we're really not sure how it works with pain. Out there, that P substance is probably the most logical that's out there. But we do know how ibuprofen is, and that's the dual acting. And we'll chat about that when we get to some alternatives. All right. So, combination pain scale, my point is, if you're going to prescribe Ultram, you're going to prescribe a hydrocodone product. A lot of the states have a hydrocodone fix. Just open up Google and just say, where do you fall on here? And Tracy and I built, and you'll see when we get to some of the towards, maybe another 20 minutes in here, you'll see where we've given you some recommendations on if it's a 1 to 3 or a 4 to 6, what to do for these patients, non-narcotic and narcotic in a sense. All right, what's some of this stuff rolling in here, Joe? I'm going to slide this over. It says ibuprofen is 125, and see, there's the acetaminophen is going to be 300. Because they changed the upper limit to 3,000 from 4,000, like 2014, somewhere in that range. So that's no surprise that that's 300. So 300 and 125. You can give 2 of those, get up to that kind of, I guess, 250 and 600. It looks like it's okay. I'll show you probably maybe a better way to get this, because this dual acting using ibuprofen, ladies and gentlemen that are out there, ibuprofen and Tylenol, 4 pills of ibuprofen, 200 milligrams, 800 milligrams. of ibuprofen. So 200 times 4 is 800. Take 2 Tylenol, 500. That's 1,000. So taking 6 pills, some water, 6 pills, not take 2, not take 3, all 6 pills, take it all at one time. That has shown to reach morphine pain thresholds. It just doesn't stay up there. So let's pay attention there. Whenever we get there, you can do a lot of work with ibuprofen and Tylenol. Again, it just doesn't stay up there like morphine. All right, let's see. Let's see if this works. Joe, let me know if you can hear this being played.
So, what have you been working on?
I'll show
I can hear it.
Duct tape? Hate to break it to you, bro. Already been invented. Hey. Ow, dude. Ow.
This is what I've been working at.
I happen to be flying from some conference. I don't watch many movies. I try and get caught up on emails, but being a Disney fan, I put Baymax on. I think it's the name of this movie. And
Hello, I am Baymax, your personal healthcare companion. I was alerted to the need for medical attention when you said, ow.
A robotic nurse.
On a scale of 1 to 10, how would you rate your pain? Physical or emotional? I will scan you now. Scan complete. You have a slight epidermal abrasion on your forearm. I suggest an antibacterial spray.
Whoa, whoa, whoa. What's in the spray
Big Hero
specifically?
6. Thanks,
The
Haley.
primary ingredient is bacitracin.
It's a bummer. I'm actually allergic to that.
You are not allergic to bacitracin. You do have a mild allergy to peanuts.
Not bad. You've done some serious coding on this thing, huh?
Program.
All right, so I'm going to pause that. It goes through some pretty cool stuff where we might be getting close to this with, artificial intelligence, virtual reality that's out there. There's a computer chip coming up here that he's going to pull out. But Haley, thank you. I always say Baymax, and it is Big Hero 6. I appreciate that. Let's see. All right, so drug treatment options, when we talk about nociceptive pain that's out there, non-opioids would be your acetaminophen, your NSAIDs, and then Tracy always points out, don't forget that prednisolone and methylprednisolone, those fall in those kind of non-opioid but steroidal, in this case, ways to treat pain. You reduce that inflammation that's out there, that inflammatory pain, you can get rid of pain that's out there. So that would fall into your non-opioid categories. When it comes to opioids, codeine, hydrocodone, Ultram, those are kind of the ones I haven't listed there. There's other ones that you're going to see, but we kind of listed these as kind of being your kind of ocular usage ones that are out there. We mentioned Ultram or Tramadol quite a few times, hydrocodone, things like Vicodin. And then codeine is an option, but it doesn't really work great for ocular pain. At least I haven't. Now, just real quick question here, Joe. Can you launch that polling question?
Yes, I can.
Marijuana is allowed in Colorado for recreational use. Is it still considered illegal by the federal government in Colorado? So do the feds still consider it illegal? Yes or no? All right. Well, that's being answered. I'm going to slide over here, check out. See, someone sent me a private message. I'm unable to answer the polls. So I am doing, okay, you can put your answers in the chat box. That's fine. 225 acetaminophen. Great movie. I do like that movie there, Haley.
All right, we had a good response. I'm going to end the poll and show the results.
Yeah, this is a good one here. If I was phoning a friend or polling my audience, the audience got it correct. It's still illegal by the federal government, right? So the federal government still has marijuana on as type 1, as I think we'll see here on this next slide. I'm going to close the polling question here on my end. So controlled substance Schedule 1 is marijuana that's out there, and it's still illegal in the United States, right? It's on the federal government, but the states have passed, hey, look, this can be used recreationally, this can be used in a medical way. So the government, US government, just doesn't go in and enforce it, right? So the reason why I point this out is be careful when you're leaving Colorado. As soon as you step on airport, right? That's federal government. Anywhere there's an airport, that's now overseen, right? Flying federal, you hear all the warnings, this and that, and so on and so forth. And that's why when you fly out of Denver, you see all those dog sniffing areas. And if you're caught transporting it, so on and so forth. Well, hey, I can do it just off property. Now I step on, well, now you're stepping on federal property. So just be, I point that out. It's still illegal in Colorado, but the US government's not going to come in and enforce it because the state and the citizens of Colorado and what other state that's out there that have passed this recreationally, again, that holds true. I just know for sure when I went out to a meeting in Colorado, Denver, Colorado, and I remember when it first passed, I'm like, oh, it's not such a big deal. Went back 6 months later, and every corner I can smell marijuana, and then all the the shops were out and thriving out there. So I just want everyone to realize how that all works. So when we talk about controlled substances, Schedule 1, that's your heavy heroin and LSD. Moving into 2, that's your oxycodone. Now hydrocodone. When we talk about how we can legislate, optometry can be legislated out of their license. Well, this was a case. It was a Schedule 3. We had in Pennsylvania 3, 4, and 5, like a lot of other states. They moved it to 2, and I couldn't use it. And Vicodin and Lortab worked great for eye pain. Couldn't do it. You can see morphine falls in here, your methadone, your fentanyl, which we're hearing a lot on TV that's out there, moving into your Schedule 3s. And as they go through, they're supposed to be less chance of addiction or safer from abuse that's out there. And you can see the one that we talk about a lot is Schedule 4 is our tramadol. And then any of the cough expectorants that have codeine fall into a Schedule 5. So state by state restriction, again, remember marijuana, we talked about this, is still considered to be a Category 1 or Schedule 1. The government just ignores it. And we talked about what happened in 2014 in Pennsylvania when I was using for my patients hydrocodone products, and then was legislated out, but then we were able to fix that, what's called the hydrocodone fix in New Jersey, and other states have now all kind of fixed that that's out there. Now, opioids or narcotics, mainstay of therapy is for the treatment of pain. That's really what they're out there for. They don't really have many side effects unless you're trying to create constipation or stop breathing. Those are all the different side effects. So their mainstay of therapy is pain. Here's really the key, that there's no maximum daily limitation. We talked about for ibuprofen, 800 milligrams. The problem with narcotics, and we're going to get to a polling question, is though there's really no ceiling effect, and that's what creates. So tolerance, right, to a medication now leads to a higher dose. And that's when, Tracy talks about when she's treating chronic pain, she might give a little bit of this narcotic for a little bit of time and get them off and try another narcotic just to keep those receptors jumping around, because if you keep them on the same medication, they end up developing tolerance, and then you have to keep getting a higher and higher dose, but then now you start affecting kind of the respiratory system that's out there. So the mechanism of action that's out here, you hear us talk a lot about receptors. When we talk about pharmacology, nothing's more important when we could talk about that when it comes to talking about opioids. We have the mu, the kappa, and the delta. And you can see here, I have it highlighted in purple. The mu receptor is what gets stimulated, plugged in by the opioid or the synthetic opioid. And when that receptor gets that mu receptor gets plugged into, that's what creates the analgesic, but that's what also creates the euphoria. Now, I want to point out one thing. If you've ever taken a narcotic and you said, hey, I kind of like the way that made me feel, that doesn't mean you're addicted, right? That just means that that mu receptor was stimulated and you got the euphoria. You'll get some meiosis. There's that sedation that we talked about. Constipation always happens. We'll talk about what you want to always prescribe. If you prescribe Ultram, even for 3 or 4 days, you want to do something like Senecot S so that you can make it mushy, but you got to stimulate it. You just can't make it mushy and have it sit there. We'll talk about that in a second. And the respiratory depression, the kappa, you get analgesic, but you also get sedation, but you get the dysphoria. And Tracy knows I'm a Disney fan, and she talked about a patient that literally came in and said, hey, man, I really don't want to ever take that again because I was having a side effect where Mickey Mouse was chasing me with a cleaver. That's dysphoria, right? And then you have delta, and that's just analgesic. So we talk about the mu, and you can see there's mu1, mu2, there's delta. I'm sure there's delta 1, delta 2, and there's some kappas that are out there. So you would think, why don't they just make analgesics that are just plugging into the delta? And the reason is this picture right over here. You can see we don't have many delta receptors throughout the body. Let me see if it's the next slide. Yeah, so this is what people think. People think like central acting, we're just kind of blocking it up. The brain is saying, okay, I feel pain. No, these delta and kappa receptors are found everywhere. That's why we get constipation. They're found in our lungs. That's why we get respiratory depression. They're found in our eyes. That's why we get meiosis. But you can see here, we have more mu receptors throughout the body than we have kappa receptors and delta receptors. And again, you can see now that's where your side effect comes from, that you get the euphoria. Again, I'm going to repeat, if you ever took an opioid and you felt like, hey, I feel pretty good, that doesn't mean you're addicted, right? Your mu receptor was plugged into, and your mu receptor responded the right way, and your dopamine reward center was being happy. So analgesic, meiosis, not myopia, sedation, constipation, that's out there, and it's always about the receptor. And again, I just threw this in here just being geeky, that there's endogenous and your opioid drugs, your pure antagonists, your mixed antagonists. You can just see how they can really get geeky about the kappa, delta, and mu. Joe, any comments that rolled in or any comments you want to make?
I'm gonna look in the chat room. I think that we are all caught up on everything, Greg. No, and I'm gonna let you keep going.
Perfect. So we have opioid drugs that bind to opioid receptors, right? Mu, kappa, and delta. We have morphine and codeine. Those are your opiates. Then you have synthetic. So this is where you're going to have people that are, anytime you have anything in nature, penicillin, sulfa, opioids, you're going to potentially have the allergy. So you can have an allergy to morphine. And as you go towards synthetic, you have less allergy. And that's why when people are allergic to morphine, you start giving fentanyl or methadone or tramadol, because they're synthetic that are out there. And then you have oxycodone and hydrocodone. Those are kind of your semi-synthetic that's out there. So just kind of breaking it down now into opiates, semi-synthetic, and synthetic. So formulations, we talked about this a little bit earlier. Tracy deals with controlled release. She deals with chronic pain. She's part of the chronic pain management, and they send people to her apothecary with a prescription, and she starts to manage. They're trying to get to a basal control for chronic pain. We're going to be dealing with acute pain most of the time. And again, unless you have maybe a testicle eye or some type of blind eye, that's just the patient doesn't want to have removed. That's the only, I shouldn't say that's the only one I can think of right now as an example. But a lot of times it's going to be a corneal abrasion, some of these things we talked about, LASIK, PRK, these epi-on, epi-off type of procedures, and you're going to have something that's short acting. So you want to make sure you look for that IR, that immediate release that's out there. So morphine is usually the standard for comparison. So as we go through, you'll see like how much of this drug does it take to be equal to morphine. So it's kind of the standard of care, like Timolol, when it comes to approving drugs, they kind of single agent. Is it just as good or can it be better? As long as it's not inferior. So it kind of judges it against morphine that's out there. But you can see here, there's morphine sulfate, the MSIR is immediate release. And then you can see here, morphine sulfate continuous release. So if you were going to prescribe any of this, if you were allowed in your state, you'd want to prescribe morphine sulfate immediate release for that acute pain that's out there. You can see here, hydromorphone, super, super strong, because just jumping down here, you can see for 30 milligrams of morphine, it only takes 8 milligrams of hydromorphone to take care of a patient for severe pain. This is used for severe pain. You might hear it as used as dilaudid. That's out there. And there's immediate release and there's extended release. So just kind of an example of how they use morphine as kind of the standard. You can see 8 milligrams, but as a reminder, there's extended release and then immediate release that's out there. Now, codeine based, we have many fall into codeine based. We have codeine itself, naturally acting opioid. So that's why you hear people being allergic maybe to codeine. And then you have your semi-synthetic, a little bit more potent than codeine. That's your hydrocodone. And then jumping down into oxycodone. Now, again, I have highlighted in as no cough, because when people come in and they're looking for, and they're addicted and they're have abuse and they're just trying to find ways to get medication. You might have a patient sitting here going, I use that Tylenol with codeine for my cough and moved up to hydrocodone and that seemed to work, but man, what really works well for me is Oxycontin. That falls into that cocaine based, and it sounds like it might be a little strong, but man, that's the only thing that suppresses my cough. Well, again, it's nice to have that knowledge that oxycodone does nothing for cough suppression. It doesn't plug into those receptors like the codeine and the hydrocodone that's out there. So again, knowing the pharmacology, knowing where things plug in can help us out when patients are out there maybe trying to try and get medications. And that's what this course is about.
Green stuff? Yeah, it's in there.
I got it.
Get that, Joe? Want to get that?
Yep.
All right, perfect.
I write them down.
All right, perfect. So hydrocodone tablets, weak analgesic. It's usually added to Tylenol. And really, I sometimes go through this slide, but you can see that there is a Tylenol 1. Don't even ever prescribe it. I don't even think pharmacists keep it on their shelves. Along with Tylenol 2 or 4, they pretty much keep Tylenol 3 on the shelf. You can see 300, 300, 300, but you can see 15, 30, and 60. And the reason why, it's just the best ratio. If you want to give 1 to 2 tablets 4 to 6 times a day, it's the Tylenol that's going to limit us. You're only allowed 3,000 now. So if you gave, if you were, and then this is pretty high, 60. So let me go back. I'll just walk through this real quick. If you wanted to get this to 60, you have to give 4 of these. Now you're getting up to 1,200 milligrams of Tylenol. If you want to give 60, now you're only getting 300. So the nice thing is, if you want to give 60, you once or twice a day for some acute pain, you get the 60, but you also get a nice ratio of 600. So it's the best ratio that's out there. So if you're going to prescribe, do Tylenol 3. You don't have to worry about Tylenol 2, Tylenol 4. You're going to do 1 to 2 tablets every 4 to 6 hours as pain. And again, remember, 3,000 milligrams, 3 grams is now the new limit for APAP, or what is acetaminophen. All right. Hydro. How about oxycodone? Oxycodone products that's out there. We're talking long acting, extended release, Oxycontin, continuous release. And then you have your immediate release, which would be Oxy IR. if we were able, maybe some states are, if you're going to use Oxycontin to treat eye condition, you wouldn't want to go with the continuous release. We'd want to go with the immediate release that's out there. 1 to 2 tablets by mouth every 4 to 6 hours for pain is needed. Remember, this is all going to follow through. All these medications are in combination with acetaminophen. So just kind of remember, that's going to usually be your upper limit. That's going to limit you to what you can do is your 3,000 milligrams a day. Sticking with the oxycodone products, Percodan, oxycodone, and aspirin. Basically, this is Tracy saying this. No one really uses this product that's out there. It was really for the people that couldn't use acetaminophen, but that rarely happens. So I guess we can mention it that if you have someone that can't use acetaminophen, you have oxycodone with aspirin. But you can see here that it is more potent. Oxycodone is stronger than morphine because you only need 20 milligrams to get to that 30 milligrams. Now, here is where, we have codeine, we have Ultram, probably, in my prescribing, this is probably once a year. Ultram is probably the majority of the time, but every so often, if a patient is in, a little bit kind of that 6, 7, or 8 scale, 10 scale, eye pain, I'll be hitting a little higher with a little hydrocodone product. And, jumping down, don't forget, we want to make sure we're using immediate release. Pretty much all of these are immediate release. And if you're going to do, it's usually 5, like Lortab, 5 milligrams, 1 or 2 tablets. So you get 10 milligrams of the hydrocodone. And now you're getting 600 milligrams of the acetaminophen. So you can go 2.5, you can go 7.5 or 10, give them 20 milligrams. But usually for ocular pain, if you just do 5 or 7.5, maybe if it was like maybe an 8 or a 9 or a 10, but usually 5, so Lortab, 5/300, take 1 or 2, you're going to do like 4 days, maybe 3 days. Let's do 3 days, and you're going to do 2 tablets 4 times a day. So that's 8 times 3, so 24 tablets. So, your Lortab, 500, 300, 5/300, 24 tablets, take, 1 or 2 tablets every 46 hours for pain. But you can see here, it's pretty potent. 20 milligrams hydrocodone for every 30 milligrams of morphine. So it's a pretty strong, medication. Here's the other one. This is another great choice. I typically call this optometry's, in a sense, narcotic or opioid of choice for treating ocular pain. But remember, there is an extended release. So we want to make sure you're doing tramadol, 50 milligrams or 100 milligrams. You can do either one. Someone comes in with a 3 on the pain scale, 3 or 4. Then you're probably going to do 50 milligrams. Start getting up to the 6 or 7s, you're going to do 100 milligrams. You start getting up to the 8s and 9s, you're going to probably move into your hydrocodones that are out there. Now, this is a dual acting, not dual acting like we were talking about with acetaminophen and ibuprofen. This is a mu receptor, and it also inhibits neuronal uptake of serotonin and norepinephrine. So you just want to be careful of patients that are taking the triptans, the sumatriptan, the Imitrex for migraine, or the selective serotonin reuptake inhibitors like Prozac that are out there. Not to say you couldn't use them. I want to reach out to the family doc. It's only going to be acute pain, or maybe moving over to a hydrocodone product. So they are dual acting, working in serotonin and norepinephrine reuptake, but also there's that mu receptor. But again, 50 to 100, but we want to make sure you do Ultram because it is, or tramadol. This is your immediate release. We don't want to be moving into something that's kind of extended release that's out there. And it started off, I believe, the history of this, we don't have to label, or it was a category 5, or that's how it started. We'll let the states decide where to put it. We'll let the state decide where to put, tramadol because it doesn't have an abuse. Well, eventually it did. And then they labeled it as a 5. Federal government stepped in and said 5, now it's a 4. Okay, so there are some abuse out there, and that's where you hear might be called trammies on the street, right? You hear people asking for trammies. Trammies is, tramadol that's out there. And again, the history of it was, okay, Pennsylvania, you can decide where you want to put it. Is it a 5? Is it a 4? Is it a 3? Then the federal government stepped in and made it a 5. Now it's a 4. So there is a little bit of an abuse going out there. And again, there's the trammies that we talked about. Joe, polling question number 5 here.
All right, they'll be up in just a second.
So this is going back to, when patients come in and they have methadone. When you see a patient in your office on methadone, someone takes, a history, be kind to them. They're coming in for their eye exam because they're probably recovering from opioid abuse. Just be kind to them, because all of them at some point maybe have been addicted to some type of opioid, or maybe heroin, something a little stronger, and they're using this methadone to kind of tickle those receptors to kind of keep those withdrawal symptoms. Anything in the chat box, Joe? Any comments you
Looking
want
it
to
up,
make?
looks like we're all caught up, Greg.
Okay.
Okay, we're doing very well. Good response rate already, so I'm going to end the poll and share the results.
Yeah, so I mean, in a sense, everyone's correct here with this polling question. I kind of felt that everyone that came in at one time using methadone was probably addicted to medication. I see that 21% or 33 people said false. And that's, I guess where I'm going with the question is, when people are allergic to opioids, basically you have fentanyl, which is the most potent, but doesn't fall into the fentanyl. It's the most potent, but it also has a black box. This is what you would give to someone, or Demerol or methadone. Methadone is used as an analgesic. It's not used that often. That's out there. So here's a little bit of a tidbit that's out there. For chronic pain or opioid abuse deterrent that's out there, it can be used for chronic pain. So a patient on a short-acting pain medication will be taking it twice a day, likely being used for chronic. So that's kind of how you tell, right? If they're coming in and they're trying to keep that basal rate, as Tracy always talks about, that nice amount of plugging into those mu receptors or those pain receptors that are out there. If you're trying to get them, you want to take it twice a day because you don't want these ups and downs. If you're just trying to keep those receptors, as a patient's going through withdrawal, or you don't want them to have that craving, that dopamine reward center, you give it once a day. So you see once a day, the patient is probably in some type of opioid abuse management. If they're taking it twice a day, they're using it for pain medication. So just kind of use that again as a superpower out there when seeing your patients.
Hey, Greg,
Now-
what about its use in alcoholism?
It's
Question.
also, they're just making a comment.
Yes.
Any of the kind of abuse disorders that are out there, they could use it, in alcoholism. And again, to try and it's plugging into that dopamine reward center. So you're just trying to keep that dopamine reward center from needing alcohol, opioids, heroin, any of those types of reward center plugins, if that makes sense.
And what about Suboxone, Greg?
I'm not familiar with Suboxone, but I know it's in the slides coming up here. So let's stay tuned to that. All right, I think it's that dual acting is what it is. Suboxone is, it's got like opioids, but we'll find out because I know I have it in here. I just know it's
Mhm.
not used that much. So when it comes to pregnancy, it's pretty straightforward. Just use Tylenol. That's out there. Stay away from opioids, stay away from NSAIDs. Tylenol is the opioid of choice during pregnancy. We'll just make that slide really, really easy. Opioid allergies, if a patient is allergic to codeine, ask the appropriate questions. If the patient is truly allergic to codeine, they're most likely going to be allergic to morphine, hydromorphone, that's out there. When Tracy talks about this during her talk, what happens is, the opioids, what happens is when you give them, it kind of like suppresses, in a sense, the histamine, but then at some point it allows it to kind of be liberated. And you get like these little pinpoint red dots all over your body because of the histamine release. And so that's not really an allergic reaction, right? It's your mast cells have degranulated or wherever this histamine is being released from. And people from taking it just get a little extra histamine and then they end up looking a little red. That's important because with all these electronic health records being connected nowadays, someone might need hydromorphone or hydrocodone or tramadol or morphine, and it says, hey, they had an allergic reaction. And now they're getting into the fentanyls and the methadones and all this other stuff when it really wasn't a true allergic reaction. The other thing too that opioids can do is plug into that barf center and cause us, that's not an allergy that's out there. But again, if you do have allergies, true codeine, true opioid, that's when you'll start seeing the fentanyls, the methadones being used that's out there. Assess allergies appropriately. It helps the practitioner sort through the actual, hey, I'm allergic to all the opioids. But I need some fentanyl. That's what really works on me. So this is why we take this course, is to try and breathe that highlight. But what I don't want to do is put the fear in. We are not the problem that's out there. I want to give people, the colleagues tonight, the ability, if they want to use Ultram, please do it. It is a hell of a lot safer than ibuprofen when it comes to bleeding out and creating other problems. I agree that there is an addiction potential that's out there. But I'm not going to talk about pharmacogenetics, but I'll probably hit that somewhere as a comment along the line. I just thought this was kind of cute. This is another kind of little break to help me, let me to take a little sip here. I thought this was kind of cute. I don't think Disney did this, but someone just put this together.
I'm fine.
On a scale of 1 to 10, how would you rate your pain?
Hey!
Hot water, Mr. Smee.
The poor captain has a splitting headache. We mustn't annoy him.
When I say go, push against my back, and we'll walk up the hill. Ready? Go.
Ow! You did that on purpose.
All right, so for the sake of time here, you guys have kind of got the point. We're back to the grading scale. Tracy and I built this one evening preparing for a lecture, and some of the drawbacks is a 1 to a 3, a 4 to a 6, 6 is close to 7. So the scales are great, and you have these different smiles. Sometimes people need words, and that's really why I like this one here. People understand 0 to 10. People understand no pain to worst pain ever. They understand faces, they need words, grading scales. So you can see here that a 1 to 3, a 1, we could probably just get away with some Tylenol with some ibuprofen. But a 3, we might want to get into low dose Ultram, like a 50 milligram tablet, every couple hours for pain. Jumping down into moderate, we have a 4 to a 6. Someone comes in and says, yeah, my eye pain's a 4, maybe some low dosed Ultram. But if you're getting into a 6, maybe we can talk about a low dose, Vicodin. We talked about 2.5 to 300, maybe a 5, 1 tablet for that. That's out there. You start getting into a 6, maybe it's a 5, 1 or 2 that we could use. You start getting into some severe pain, Tylenol with codeine. Again, now you have the Vicodins or the Lortabs. Remember, we talked about 2.5 to the 300 all the way out to 10. You start giving maybe a 7.5, 2 tablets, every 4 to 6 hours for pain that's out there. I'm not sure if any of the states have morphine sulfate immediate release, but you can see here, what we would be doing for severe pain if it was needed. That was out there, maybe like a true laceration to the eye, morphine, hydromorphone, or if they're allergic, you're getting into some fentanyl that's out there. So with that being said, one of the main problems with opioids is what? Is it a low ceiling effect, a high ceiling effect, or that there is no or a lack of ceiling effect? Where is the problem? I mentioned it earlier. Is it's a low ceiling effect, a high ceiling effect, or there's just a lack of a ceiling effect when it comes to opioids? Opioids, this is where the issue is.
The question came in, can't people's pain thresholds differ greatly?
Oh, absolutely. And that's where we come in with the pain scales, right? You see someone that comes in with a mild abrasion and you say, hey, the last patient I just gave Tylenol, or I gave ibuprofen 400 milligrams, and the next person walks in and you're giving Ultram 50 milligrams. So patients' thresholds are all over the place. So that's why we use a grading scale. We see it all the time, right? I tell this story all the time. Patient comes in and they have oh my gosh, doc, I can't see I don't know what happened. I can't see, I'm blind. I'm starting to think, geez, what happened? Macular degeneration, macular swelling, cornea problems, and it's one click of myopia. I go click and I go, oh my gosh, what'd you do? Gave you a quarter of myopia correction. Next person comes in, I'm like, oh, this is going to be great. Look at their auto refraction. They're going to love me. It's like a 4 clicks. Click, 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 click. Where's the reaction? Well, let me show you that one more time. Click, 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 click. Doc, what do you want me to do? It all looks the same to me. So we see it all the time with our refractions. We see it, with pain. We have patients that come in that you think that they ripped off half their cornea and they have like a 0.5 millimeter of an abrasion. But be careful, because I think we miss a lot of neurotrophic keratitis. So there could be patients out there that have a lot of cornea problems, but they have neurotrophic keratitis. All right, so it looks like we just kind of climb here. Low ceiling effect, high ceiling effect, and lack. So it looks like the majority got it here, 63%. We talked about it a little bit earlier. It's the lack of a ceiling effect, right? So that's the problem, is that there is no ceiling effect to the. You have a ceiling effect with your peripheral acting, with your NSAIDs, with your Tylenol. That means if you give 800 milligrams of ibuprofen, you've reached it. If you give 1,000, they don't become tolerant to it. And if you give 1,000, it doesn't hit the pain receptors as peripheral acting pain receptors. But those mu, those kappa, those delta, they do become tolerant. And if you give 50, it'll eventually need 75. And if you give 75, 100, and 100, 125, you get it. You have to keep giving. There's lack of ceiling effect that's out there. So tolerance is the escalation of dosage to maintain effect, whether it is analgesic or euphoria. It happens to everyone. You give someone an opioid, they will become tolerant over time, whether it's for pain or whether it's just to get that euphoria in that mu receptor that's occurring. So opioid adverse effects, constipation, again, anticipate it. If you're going to give an Ultram, give a Senna S, and the S is important here, everyone, because you can make it soft in the bowel, but those mu receptors, kappa delta, don't allow the poop to be pushed out and stimulated. So you can make it mushy. So Tracy always says, you got to have the mush and the push with it. So do something that has a stimulant. So every time I do an Ultram, every time I do a Lortab, make sure that they go down to the aisle and get some Senna S. So it's kind of two things that have to happen. So constipation, sedation, the euphoria, those U receptors, dysphoria, capia receptors. You're going to get a little bit of itch. You're going to get that histamine release, and you might get some vomiting because it's plugging in to the barf center of the brain there. We get some confusion, meiosis, respiratory depression that's out there. Be careful, because this is what kills people, right? I just saw somebody the other day, like, oh yeah, give me a beer, give me a Tito's and whatever, and I'm going to take my Ultram. I'm like, oh my gosh, do you see what they're doing? All these CNS depressants that's out there, and taking an Ultram or some type of Lortab, with a double shot of Tito's. Oh my, geez, be careful with your muscle relaxers and your sleeping agents and your antihistamines. So opioid effects and adverse, withdrawal symptoms, short half-life agents are more likely to cause the abrupt withdrawal symptoms, the sweating. So they plug in and then they go away, and that's what creates the agitation, the irritation that happens. And the respiratory effects, inhibiting cough, right? It inhibits the cough centers that it's out there. And this is what things that happen to things like Michael Jackson and the famous people that have had bad things happen with opioid abuse, is as they're given that high level to get that euphoria, now it doesn't take much to shut down those breathing centers, and this is what kills the person. So this is now where naloxone comes in, and that Narcan. You squirt it up the nose. The beautiful part, it's all about the receptor. Luckily, Narcan has a higher affinity for the breathing center receptor. So when the opioid is plugged into it and the patient is not breathing because they have too much opioid, they've saturated all those receptors, they can't breathe. Boom, Narcan comes in and says, get off of there. Boom, and plugs in, and the patient literally does breathe again because of the high affinity. However, we've seen patients that have been out there in the addiction centers, as soon as they start breathing, right, they need to go back out and get that stimulation again, because they need that euphoria. And those are the patients that need the most help, right? Or the ones that have that problem, that addiction to it. So you can see here that, Narcan and morphine look very, very similar. And we're using this science and pharmacology to knock it off that receptor, and it allows the patient to breathe again, or what other adverse events they might be suffering from. So I believe right here, Joe, here it is right here, this Suboxone someone was asking about. It has an antagonist and an agonist in it. It's a combination. So this was kind of what came out of, trying to, put some naloxone in it, puts, in with a with an opioid. When Tracy talks about this, because she's the pharmacist, on paper, it sounds good. It looks good, but it doesn't really work great, at least in her opinion. Obviously, I don't have any experience in this area, but this is what came out of, the drug companies and, in this addiction that we have, in this opioid crisis, putting in an antagonist and an antagonist. And this is what one of the docs was referencing with Suboxone. All right, so opioid mixed agonist and antagonist, again, trying to, you could do it with morphine, you could see oxycodone, extended release. This again was just trying to come out of when we talked way back at the beginning of these different types of outcomes for this crisis that we're in. So substance abuse history, avoid all opioids in patients that have a history of heroin. How about patients with alcohol abuse? It's a judgment call, but probably we as optometrists, if someone comes in and they have eye pain, we have some alternatives out there. I would say alcohol abuse, stay away from the narcotics. You know, let the people in the chronic pain kind of figure that out. When looking at the state regulations, there's always, you know, we have to talk about true addiction. This was what was called, formerly known as psychologically, you know, patient is psychologically dependent that's out there. True addiction, this is really simple, compulsive despite harm, right? I'm going to reach my hand through that fire, through that broken glass, so I can grab that oxycodone and take it, crush it up, snort it, inject it, whatever. Compulsion despite harm. I'm going to stop breathing, get Narcan, and I'm going to take that. So that's when you hear true addiction, compulsion despite harm. Quality of life is not improving by the medication, and eventually it becomes compulsive, wanting without liking. So that's when you hear true addiction, what that is. Identify behaviors of abuse and addiction. Fast talkers, strange allergies. I kind of referenced this throughout the talk, like, hey, the oxycodone, you know, I need it because it really suppresses my cough. Are you sure it suppresses your cough that's out there? You know, these strange allergies, excuses of lost meds. Those are things that we need to talk about. Those identifying those behaviors. You know, ways to respond: avoid being bullied, avoid acting like you're judging the patient, use tools that are out there. Basically, now it's pretty easy. You have all the states, I believe, have prescription drug monitoring programs where you can go in, log in, and put the patient's name in and see if they have been on an opioid. You know, there's legal and ethical issues that are out there. I do have an Oklahoma license, so I know I received this. This was back, you know, in February of this year. You know, hey, here's your prescription monitoring program. You know, please sign up. Here's the link. You know, in Pennsylvania, this is where I practice. They have it in Pennsylvania. I'm sure the states where you practice, they have these prescription monitoring programs that you can log in. And if you prescribe it, you can log it in there so that the patient has been plugged in. So ways to combat abuses, you know, what they've done is this is how the medicine used to be. This is how they would crush it up, snort it, and then they put this gel. But, you know, these are all great. This is Oxycontin, continuous release. Now, remember, true addiction is compulsion despite harm. So they'll either suck the coating off or use things like rubbing alcohol to take the coating off. And now the rubbing alcohol we know is not good when it gets into the body. You know, this was they heat it up and heating it up and putting it into a needle. But again, heating it up, it clumps up and, oh, I can't get it into the needle. Again, there's all kinds of ways on the internet to find ways to get that coating off, suck it off using alcohol, other things that's out there. But these are ways that they're trying to get these medications so that they cannot be abused. Alternatives when it comes to opioids. I'll go through these pretty quick because I see we're getting close to the time, and I want to show a couple cases. So alternatives for pain control. We have NSAIDs. We talked about the COX-2 inhibitors. They're still out there. Corticosteroids. You know, integrative approaches. There's acupuncture. There's surgical interventions, nerve blocks, spinal cord stimulators. I know Tracy has some damage, and she uses a spinal cord stimulator to control her chronic pain that's out there. And some of these have synergistic effects when used together. But what can we do in the office? I think Joe referenced this. Bandage contact lenses, and it's actually billable, right? 92071. I typically use an extended wear contact lens because it's approved to sleep in. But you can use a -1/4, +1/4, whatever you want to use, that's out there. So remember that bandage contact lenses are an alternative. Joe talked about atropine. We like to talk about your Medrol dose pack that's out there. Tracy has this in here, this millipred. No one really uses it. So that's why you see most of the time, a 6-day Medrol dose pack, the prednisolone one. We kept getting questions on that. What about the prednisolone one? No one really uses it out there. So we'll just kind of keep going through. Adverse drug reactions. I think we're all pretty aware of what can happen with steroids, the glycemic control, the GI upset. Another alternative is acetaminophen and ibuprofen. And it's going to click through here and just get to this slide right here. Right here, I've been doing this for years, teaching that back in the day, it used to be 4,000. So now it's down to 3,000. I think for acute pain, my opinion, you can fall either between 4 and 3. So what I do for my patients is right here, 2 and 2. If I don't have something that's too inflammatory, 2 ibuprofen is great for analgesic. That's all you need, analgesic. So we're talking about tonight, pain. And 2 Tylenol, 4 pills. I don't have to worry about them getting confused. But what you do have to tell them is all 4. Doc, are you trying to kill me? No, because ibuprofen prescription strength is 800 milligrams. You can go buy 200 at the store. Take 4. That's prescription strength. No, I'm not trying to kill you. So 4 pills all at one time. And that has been shown to get to the levels of morphine. If you're trying to control some inflammation, right? There's some swelling, it's a trauma. You know that there's going to be some inflammation going on. When you give 800 milligrams, all you need is 400 to get analgesic. But if you want something that's going to cover inflammation, and we talked about inflammatory pain way back at the beginning, what you can do is give 4 pills of ibuprofen, that's 800 milligrams, and again, 2 Tylenol, now 6 pills. Doc, you trying to kill me? No, I can write prescription strength if you want, all at one time. That will help with inflammation and pain. And you can see over here with the other aspirins and Aleve that are out there, what the daily doses are. But this right here is what you need to know. See right here, 3,200 milligrams. You can give 16 tablets a day of Advil, right? 4 times 4 is 16, and that gets you 3,200 milligrams. And then you could decide of 500 milligrams if you want to do that 3 or 4 times a day. Again, it cleared out in the liver, and you can create some liver toxicity. So an alternative here would be things like CBD. So I'm going to go through this pretty quickly. I touched upon it earlier. We're starting to learn a lot more about CBD. Actually, Tracy and I have a 2-hour lecture on CBD and THC. It's more the CBD side, because now we see in 2018, they've taken CBD from being a Schedule I, and now you see CBD stores everywhere that's out there. So the prohibition has been lifted. It's kind of funny. I'm not sure if you're a conspiracy theory, but 80 years ago, they passed the Marijuana Act, and then shortly after then morphine came out, the opioids, and then we now see the issues from that, right? And then 2018, it's now not considered a Schedule I, and this is what's really cool. You're starting to see the NIH starting to do studies on this. And we're learning about the endocannabinoid system. Like we always hear about the arachidonic acid system. We're still now in its infancy learning about THC and CBD. Here's for the eye. CBD can cause an IOP rise. THC can cause it to go down. So CBD by itself can cause it to go up. Also, you got to be careful because there's a lot of CBD 1 and 2 in the retina. You can start getting scotomas that are out there, and that's from the marijuana side of things. The Delta 9 THC that we talk about, and that's what creates it. So there's different types of cannabinoids that are out there. So just, it's an alternative. I wanted to bring it up. I'm not sure how well it would work for acute pain. It's more or less these chronic pains that are out there. There is a synthetic cannabinoid. They're trying to target the CB1, CB2, but nothing ever really works as well as the natural. So everyone now is selling it. Everyone is talking about it. Just, be aware, CB1, CB2, the endocannabinoid system, it's an alternative. Again, I really don't see the benefits in acute pain, more or less the chronic pain patients, which would be the post-herpetic neuralgia that's out there. There's full spectrum, broad spectrum, and isolate. You're probably going to want to play around in the full spectrum or broad spectrum. Isolate, when you start isolating things out, it doesn't, really work that well, and you have to give 5 or 10 times more medication. So we're starting to see studies, here, Cymbalta and Lyrica and fibromyalgia, full spectrum cannabinoid, 62% more effective. Hemp-derived CBD, full spectrum with opioids, 75 patients, 15 milligram soft gels, 53% of the patients stopped or decreased their opioids. This is for your chronic pain patients, and 94 reported better sleep. Again, just trust me, the endocannabinoid system, the CBD, will probably be used more than we thought as we start understanding how this is worked. CBD with drug addiction, right? Decreases the reward facilities, the seeking behavior, the opioid dependence, decreased opioid seeking behavior. These are all things that are being studied by the NIH that's out there. So just things you need to remember: dosing, delivery, interactions, and monitoring. Even though this isn't over the counter, we still need to be able to prescribe CBD that's out there. And things to look for in the company is, they all say it's medical grade, but maybe ask for their certificate of analysis that are out there. Inspect and the spectrums they have, if they have isolates or what type of testing they do. All right. So CBD, we talked about that. My comment here will be our associations fought hard for our ability to do opioids. So, I was president of the POA in 2010. I sat on the AOA board for 3 years, 2013 to 2016. The key that the associations are supposed to do is create opportunity, right? So glaucoma, there's 45, 40,000, 48, depending, retired people graduating. So just to say 40,000, 9,000 less than 20, right? That's not majority, but 9,000 optometrists prescribe 90% of the glaucoma drops. That doesn't mean we should take it away, right? That just means if you want the ability to treat glaucoma, there it is. States are doing GAGs, states are doing SLTs. You have the ability to have a DEA license. I would encourage you, every state that's out there that has a DEA, get it. I just renewed mine. I think it was $800 and some dollars, $888, $890. But what that does is, even if I only use it 3 or 4 times a year, that allows those who are out fighting and expanding and protecting to say, look, there's an opioid crisis, and those optometrists have DEA, and they're not part of the problem, right? If we don't have them, then they say, look, they got it, they didn't use it, they don't need these privileges. It just helps the profession. So if you have the ability to get a DEA, get it. Even if you don't use it, it really helps us out as those that are out there expanding and protecting the profession. All right, cases where I recently used my DEA. So let me just kind of show you. You can use it on things like this. This person, she was talking to her daughter. She was curling her hair. She said, "What, honey?" And she got some well done barbecued. Not have to worry about infection. That curling iron's pretty hot. Probably not many bugs survived it. Not only did the epithelium. So this was a nice little eschar, nice little thermal burn to the eye, down to the conjunctiva, lots of pain. This is a patient that I use something like Ultram or maybe even hydrocodone on it. I don't have it, but this would be a good case. You can see large abrasions, orbital trauma, blowout fracture, scleritis that's out there. This is one that I thought someone was trying to hustle me, right? So I was, I'm all paranoid. People are coming in trying to get opioids from me. This person was playing with a razor blade and they went flying by their eye and they think they cut their eye and it hurts. And I'm like, all right, whatever, as I look in there. But if you look right here, we've got a little bit of a cut right there. But now I used my OCT to see what was going on. Here's that nice little self-induced RK incision they gave themselves. And look how deep it is. You can kind of see some inflammation already starting to happen right here. So I wanted to be a geek and I wanted to measure it. We are 407 deep here. And at this part of the cornea right here, we're 600. So we'll just use numbers of really easy. 400 over 6, that's 2 over 3. We're 66% of the way through. Another few microns, we'd have been all into the anterior chamber. How many corneal nerves, how many plexi run through there? That's why this patient was in a lot of pain. This was, again, another Ultram patient. This was another, hydrocodone patient. Again, pull up the pain scale. Where do they fall? They're falling towards that 6, 7, 8. You're going to move into the hydrocodone. If they're a little bit closer down, as someone mentioned, there's different thresholds to pain. You can use Ultram that's out there. This patient here in Pennsylvania, we love to do our own car work. So this patient in April was trying to get from salt and rust and whatever, some type of changing brake pads. Well, screwdriver slipped off and they gave themselves a nice little LASIK flap. I did have this one measured with OCT. Then it went halfway through their cornea, but you can see a nice little LASIK flap, nice little hyphema, misshaped pupil. And then not only did the screwdriver bounce off the cornea, went up under the eyelid, a nice conjunctival laceration. I said, probably Tylenol and ibuprofen aren't going to manage this patient. Definitely, Joe mentioned 1% atropine. We have a hyphema here. We want to put that iris to rest. So atropine, some steroids, and then a Lortab or Ultram based upon the pain scale. I'm going to go to Dr. Google, open it up, see where they fall, and then document that in the chart, and that will help you out with that patient. This was a DSEC patient that never went back to Will's Eye in Philadelphia, and they had tons of pain, and their daughter came and said, Dad, we got to go figure out why you have all this pain, and we have a nice endophthalmitis here. So we were able to put this patient on a couple days worth of, Ultram or again, Lortab until they got back to their cornea surgeon in Philadelphia. And this patient ended up losing their eye. It was enucleated. They couldn't control the infection. But I could get them to be somewhat comfortable until they got back out to Will's Eye that was out there. So with that being said, Joe, we should be pretty close to landing this ship on time. So are there any questions that are out there? And I want to thank the audience.
I think there are two things that had come in. And they came in a little while ago, but I didn't want to disturb your rhythm because they were pretty general. Talking about people's pain thresholds. So if one person's 2 is another person's 8, is there really any point to the scale? Your thoughts, Greg?
Well, I think the scale allows you to, if a patient comes in, to why you justified on let's say what the problem is. Someone comes in and has a 4 millimeter abrasion, a 3 millimeter abrasion, and the other patient has the same millimeter abrasion. So why did you do ibuprofen and Tylenol on this patient? And then why did you go to Lortab on that patient? I think it justifies giving why you did what you did. So yeah, I like using pain scales that are out there to help justify, because if you pulled those 2 records and sat side by side, what are you trying to do here? Why did you do Lortab on this patient and 2 Tylenol, 2 ibuprofen on this patient? So yeah, I think it justifies for what you're doing.
Yeah, Greg, I agree. We're looking to manage the patient, and you may have something that you think looks horrendous, but their tolerance is quite high. So there's no reason to, I think, go over. So I think the subjectivity is very helpful.
Yeah, Joe, that's a great
Mhm.
comment. I mean, I like that because, hey, you got a 4 millimeter abrasion. Let me knock you out with some Lortab, and maybe they only need the that's the other way of looking at it. It's a great point. So thank you.
Okay. With two current state licenses, one enabling the person to do a Schedule 2 and one a Schedule 3 as most potent, can I legally prescribe a 2 while practicing in the state with the 3 as the strongest?
Oh boy, say that again.
Two state licenses, one enables them to prescribe as strong as Schedule 2, one can do, and one state allows Schedule 3. Can I legally RX Schedule 2 while practicing in a state with Schedule 3 as the strongest that's allowed?
You're gonna have to follow the state that you're practicing in. So again, I have an
Mhm.
Oklahoma license and I have a Pennsylvania license. I'm allowed to do SLTs and some other narcotics in Oklahoma, but I'm not going to use that license in Pennsylvania while seeing patients. So if I'm practicing in Pennsylvania, seeing patients in Pennsylvania, I have to follow that state license. So follow the license where you're seeing the patients. That's your highest ability to do.
Does this course fulfill Florida opioid requirement? Unfortunately, no. Florida is very strict in the Department of Health. There are about 5 courses in CE Broker, which are online, ranging from $0 to $100 costs that are approved in Florida. Greg, would you say
Yeah,
a short course is low risk for addiction to most of these pain medicines?
Yes, yeah, short. So here's where I was going with they're called pharmacogenetics, right? I was just at the academy and sitting with all these people about genetic testing in glaucoma, genetic testing for cornea, genetic testing for macular degeneration that's out there. We also now have a way that's coming down to, as we saw in that Big Hero 6 movie when Baymax came out, I scanned the body. I didn't play the whole thing and how it's going to play out, artificial intelligence, but pharmacogenetics are going to be able to be done to see who would be, potentially addicted. Now, in an acute situation, you're not going to be able to do genetic testing. Okay, you just ripped off your cornea. Let me do some pharmacogenetics on you. But the patient might come in already with that data that's out there. So pharmacogenetics, they're going to be important. We'll be able to tell who those mu receptors and those dopamine reward receptors will be out there. But long drawn out way to say, optometry is not the cause. You can never say always and never. So we had 100 patients and we used Ultram and hydrocodone. I would say that there's a potential that one of those or two of those can become addicted. Those mu receptors get tickled, but it's those chronic pain patients is where we talk about this opioid crisis.
Greg, anything else come in, or is just your virtual round of applause? I mean, that was a great lecture, and they're complimenting you on it and thanking you. So I think we can land this one tonight.
Perfect. I want to thank everyone for taking it. Joe and I, we really value everyone that's here tonight, trusting us with their education. I'm seeing the virtual round of applause. You guys are very kind, and I'm glad you liked it. If we have to learn from this, we might as well try and make it enjoyable. So thank you.